It really is my privilege to welcome Professor Ben Mol from Monash University. He's worked tirelessly on clinical trial capacity in women's health throughout Australia. He's also developed extensive and very long-lasting collaborations with Asian universities, resulting in huge randomised control trials. So he really knows his stuff. He's involved in individual participant data meta-analyses, which is where data from randomised control trials performed almost anywhere in the world on a relevant topic come together to be really important. And he's worked on systems to detect data fabrication in RCTs. Published more than 1,600 papers, supervised more than 130 PhD students. So I really don't know what you do at your time. You described yourself as an animal. You said you're already a mole. It's in your surname, for heaven's sake. But didn't let him get away with that one. It doesn't really describe this persona of someone who's so busy. But we like the concept of being an eagle that oversees everything. And I think that's really true and very scary when you're talking about data fabrication and RCTs. So really watch out. Please welcome Professor Ben Mol.
Yeah, thank you for that kind introduction. And thanks to Matt, Vicky, WIRF for the invitation to come here. And I'm sorry to speak about kind of a negative topic that is maybe in contrast with all the positive things that we have heard this afternoon. So these are my disclosures, and I took advantage of the invitation to travel a little bit through Western Australia up north. A week ago, I made this picture. It comes back in the lecture, and you can think of it what you want. But I think it is a reality that there are people in our society who have feelings and emotions that make you picture your car like this. So I would say my core business is making medical knowledge, and I do that for 30 years now. And I do that because I believe that if we have good medical knowledge into clinical guidelines, that will improve patient care. So I support process of making guidelines, and this is an infertility guideline that advises on how to deal with unexplained infertility, and it has a statement in it on fibroid removal with a reference to a study of Cassini. So diving into that study, in the bottom, the authors claim that there is statistical significance. But if you recalculate the data, it is actually not statistical significance. So their claim that the treatment could work is incorrect. And this comes from authors Cassini and Unfer. So what I do as a routine, if I read work from authors, I go to their whole work, and this is other work from Dr. Unfer, where he does 2 different studies on phytoestrogens to see if that can improve the outcome for postmenopausal women. So these are 2 different studies published in Fertility Sterility, a top journal in our field. They're published in 2004 and 2006, but look at the baseline data from the 2 studies, different patient groups. They are identical. So the 48 or 49 plus minus 4.3 comes back in 2 papers, and that happens with all the baseline papers. I flagged it to the journal. The right paper is retracted now. The left one has an expression of concern, but it is clear that there are problems here in that the underlying data of these studies are not true. This is another example. This is 2 studies from Egypt, where Dr. El Inani is a common author. One is published in 2005, the other in 2012. And the same is happening, different intervention, different time period, different patient numbers, but there is a large similarity between the baseline table, not identical, but each green dot indicates the similar number, and a red dot means that there is a 0.1 difference. So this has taken, in my career, I think about 6-7 years to come to the awareness that this is a problem that is really affecting us. I will discuss how big that problem is, look at implications for guidelines and practice, talk a little bit how to detect it, and then see what we can do. So where we talk about, if you look in the spectrum of things that go potentially wrong, you can have unintentional mistakes, but here I talk about falsification and fabrication. That is really, apart from illegal human experiments, the worst thing to do. And I do that because my base is in the Netherlands, Amsterdam. This was 25 years ago when I got my PhD thesis, which really formed me. And from that time, I also was taught that if you have particular problems, you can talk about the relationship and you can talk about the importance of outcome. I'm on the right side here, so I'm not willing to compromise on this issue. And I'm happy to collaborate, but if needed, I'm going to go compete and fight also. So that is an introduction. So how big is this problem? You could look at the number of papers that are retracted in the medical literature. So that is a rise since 2000 onwards. But it's not such a good measure because the process of retraction is very difficult, although it is increasing. This is a later slide that shows that in the year 2023, more than 10,000 papers out of the medical literature have been retracted because there was a problem with it. Another way of looking is looking at what is submitted to medical journals. This is John Carlisle. John is an anesthesiologist who is editor for the journal Anesthesia, and he looks at all the RCTs that are submitted to the journal. And from the 526 RCT, he thinks that around 15% has problematic data. If he asks for the raw data, that percentage increases to close to 50%, and 25% of that he thinks is completely fake. And unfortunately, that comes more from some countries than from other countries. And John Ioannidis, after he read this, wrote a commentary and said, well, if this is true, if I extrapolate that to the whole medical literature, then it might be that there are hundreds of thousands of fake papers. So back to our own field, women's and children's health. This is progesterone as a treatment to prevent preterm birth, where the Cochrane review, if you take all the literature together, and I think this is a source that many of us use almost blindly, reduces the probability of preterm birth and subsequent poor neonatal outcome with about 50%. We've done then, with an international collaboration, a meta-analysis with raw data. So that means that you write to the authors and ask for the data. And the outcome was that 32 people shared their data, 17 did not. Europe did pretty good, 9 out of 10. The US did pretty good, 14 out of 15. Australia was the best, 1 out of 100%. But the problem is unfortunately the Middle East and Egypt, with a very low number of authors that share their data. And the consequence is that this was the Cochrane calculation with 50% reduction. But if you take the people who share the data, then the reduction is not 50%, 20%. Still, luckily, a beneficial effect, but it shows that there is a consequence. This is in vitro fertilization and endometrial scratching, a treatment that is widely applied. And again, we did an individual participant data meta-analysis where we got, let me see the number of studies that we had. I think it was somewhere in the 39, 14 people shared data, and about 23 did not. And then when we got the data, two studies actually were not suitable because we couldn't reproduce the data. And these were the countries of the people who did not share data. So I'm doing that now as a routine in meta-analysis. So these were the first two that I showed, but we've done it for a whole series of topics for an overall number of about 300 RCTs. 200 people did not share data, 100 did. And from the 100 that shared data, 10% is still problematic if you get the data. And there, it seems that these data are unreliable. So some examples of that. This is a data set where in purple and in orange, the same strings of data for birth weight and week of pregnancy occur. Well, that comes from data fabrication. Here is an example where the same patients come back twice in the data set. A lot of times that doesn't happen by chance also. The same here, so each kind of yellow or green bar means that the patient characteristics are exactly the same. And the fabricator of the month is this study that actually sent us a spreadsheet. It is in Cochrane, right? In a spreadsheet with a random generator in the spreadsheet for BMR. So that is one way, but you still look here at individual studies. If I take a bigger macro perspective, then in one of my fields, reproductive medicine, and we started today actually with Cassie, who talked about her journey as an infertility patient. 1,400 RCTs are there in the field of reproductive medicine in the last 10 years. And 50% of these studies come from 3 countries, China, Iran, and Egypt. And at Turkey and India, and you're at 66%. And for the European countries, Italy is the biggest provider. And I know that this is a sensitive thing. We're in a multicultural community here. I said that this afternoon to somebody I was talking to. The 2 best things of Australia are tap water and the fact that we are so multicultural. And it is sensitive to call out particular countries, but I have to weigh that against patient safety. So my question to you with this introduction, do we think we have a problem? Based on the above, I think that 30% of the RCTs, at least in our field, women's and children's health, are fabricated. And I think also that has implications for guidelines and meta-analysis. So these are examples of meta-analysis that have been retracted because after the meta-analysis was published, it was found out that there were problematic studies in it that changed the conclusion. So the fetal pillow, for example, during cesarean section was recommended already in the NICE guideline based on problematic data. And this is the suggestion that sildenafil is good for pregnancies complicated by growth restriction, and that work is also retracted. I told you I do meta-analysis with individual data, and I think, unfortunately, that within Cochrane, we have to go to this kind of pictures where we separate the trustworthy data from individual participant data or studies that we consider trustworthy as compared to studies that are not trustworthy. And the importance of that is that the overall conclusion here of this comparison is that oral misoprostol is the better drug for induction of labor. But if you look into the trustworthy data alone, that is not the case. And then there's actually no difference. This is a guideline on subclinical hypothyroidism from the American Society of Reproductive Medicine. So one of the leading societies recommends that should be treated 10 years ago. Now the guideline is updated, 1 study is removed, and the recommendation is not to do it. And ASRM actually then doesn't want to do any further investigation. If I write to them, what are you going to do with that study, etc., they say, we're not going to correspond on any issues with scientific integrity. This is another story. Helena Teed, who is a leading researcher on PCOS globally, we've updated the guidelines. There are 100 studies that inform those guidelines. When we applied a framework to see which studies are trustworthy, we lost 45% of the 100 studies. So what I just showed, and I'm not going to repeat that, but it's written out here, is that there is a large number of clinical guidelines and meta-analysis that have problems because there are untrustworthy data underlying it. So this is my position. I am not going to, I'm going to listen to what you say and the discussion what we have, but I'm not going to accept and walk away that this is happening. And the reason is first patient safety, but also trust in science and public trust in science. And here comes my picture back, that this has a consequence for all of us, because people who have difficulty trusting us will use this fact, so to say, to kind of question what we are doing. Recent paper in BMJ estimated that there is about a 10% chance that problematic studies and RCTs actually influence meta-analysis. So what can we do about it? That's a journey also. We have developed a checklist that editors can use, or people who do meta-analysis. I'll not go into detail. It's not rocket science. It's just using your common sense and see about which studies are done. If a normal cohort of pregnant women adds with the gestational age before 38 weeks, that cannot be true. If an IVF study that reports on live birth is submitted 6 months after the last patient recruitment, that can also not be true. And you can use statistics. So we are working on software to recalculate all the statistics of papers that we see. We're pretty far with using AI for that. And a very powerful thing is actually looking at RCTs. Maybe a bit of a technical paper, but this shows the cumulative distribution of p-values from one institute, Suez-Canal University, where about 20% of the p-values of the baseline characteristics of RCTs are statistical significant. That line should run from here to here. So this clearly shows that these data are not randomized. And my view is that we really should take action against these type of institutes. As said, I'm not accepting it. So I've written I think it's now at 1,200 different papers that have been published to editors and publishers. This is a summary we published earlier. So this is about 800 papers. In about 80% of the cases that have been come to a conclusion, the editors and publishers says, you're right, it's going to be a retraction or an expression of concern, but it takes an enormous time. So in terms of time, after 1 year, 12% of the cases have come to a conclusion, and these investigations goes on and on and on without an investigation. Imagine that it would be Qantas. Are you flying Qantas? Yeah. So Qantas would say now, yeah, we're faking 30% of our maintenance reports, right? It wouldn't last until tomorrow. And here we talk about medicine and everybody thinks it is a normalcy. I don't get it. So it happens over all publishers. It happens over all different journals. There are exemptions. This is a Dutch colleague, Frans Rauman. When I pointed him at problematic papers in his journal, he investigated and retracted 18 out of the 19 papers within a year. So it is possible in the current regulations. But, and I give some examples where no action is taken. These are studies on the prevention of postpartum hemorrhage. So maternal mortality cause number 1 globally, rectal misoprostol, oral misoprostol, the same first author. Studies are done in the same period, which is already very difficult. But then the control group has all similar numbers. This is Obstetrics Gynecology, the Green Journal, so our leading journal. And the response of the journal is, after an investigation, we've decided not to pursue any action against the author, as we do not believe that there is ample evidence of misconduct. I really cannot believe that they are writing that. And the papers are in Cochrane and inform the current guidelines. This is another paper about premenstrual syndrome and swimming exercise. It has a picture on how to swim, but there is not much swimming on it. And I actually found that picture in a Vietnamese website long before the paper was journaled. And you know what the response of the journal is? We're going to remove the picture because we're going to be accused of plagiarism, but we leave the paper as it is. I really couldn't believe that. I mean, many women in the room here, if one of them with premenstrual syndrome wants to talk with me and write to this journal, I would be very grateful. Dr. Safariniad has many papers. I think he has 40 retractions already. I'm not going into the anomalies, but if I write to the publisher Wiley, they say, we have followed the proper process, so we're not going to take any action against these papers. This is that particular journal where the editor-in-chief, Rolf Henkel, actually published with colleagues of Egypt. I said, do you trust this data? He said, I can send you the data set. Well, here is the problem. This paper is based on 2 times the same patients double in the data set. And this is more than 2 years ago. No action has been taken. Study from Italy, identical numbers or almost identical numbers. And fertility sterility says we've seen the raw data, we're not going to take any action. So the list goes on and on and on. And the responses from editors are, I really have no time for this. The journal gets 80 submissions per week. This editor who wrote this was actually a fabricator himself. It exists in all specialties. We're working, please be patient. And this one, we cannot keep up with the number of complaints you send to us. And I said, no, the problem is that I cannot keep up with the number of fake papers and problematic papers that you publish. We're laughing here, but it's a lonely journey. My own work has been challenged and investigators. I've been accused of being a racist. Tough stuff. Complaints at my university. I was just actually reading with the lawyer of Monash because a couple of Italians are not agreeing with what I say about them. Complaints about ACTA, with ACTA, so that is pretty threatening also. Legal threats, and one of my Dutch colleagues said, I'm really concerned about your mental health. Well, I've pushed 250 papers in retraction and 100 in concern. The other good thing is there's really a change. So this is the number of RCTs in obstetrics gynecology from Egypt. 5 years ago, 70, now it's less than 10. So there is everybody knows it, right, and doesn't accept these papers anymore. The Economist wrote about it. Interesting. So one of the interesting comments was, it's interesting that the comment has to come from outside medicine and not from inside to flag this problem. But I mean, if you read the news this morning, Kennedy roasted yesterday about his vaccine policy in the U.S. vaccine. He kind of used that gray zone of retractions to justify their own policy and mistrust in science, so to say. And there again is the. So that is a thing, I think, where we have a responsibility also. I'm not saying that this is right, but if we have a lot of problems in our own data, then you can wait until other people criticize us. And outside medicine, the response is completely different. So Daihatsu faked their safety reports. They just closed the factory. And what about Boeing, right? That was completely unaccepted. I don't know where we are with time, but I'm glad I put this slide in because Cassie this morning or this afternoon started off with starting her journey about endometriosis and infertility and closed tubes. And this paper was published this week about the relation between endometriosis and pregnancy outcomes. Well, for the young doctors with a trained eye, can you see what is wrong with this particular paper? Look at the percentages. So it's a small study, 25, but then 5 from 25 is not 5%, but it should be 20%. So these percentages don't add up. That is the same in table 2. But then in table 3, it turns out that the sample size is actually not 2 times 25, but 2 times 100. So this comes through peer review and is published 5 days ago in our field. And I think it's basically these authors realize that they're going to look at, so they make their sample size a little bit smaller, not to be detected, so to say. And it's not an RCT, and it might not really influence pregnancy, but given what we have heard this afternoon, and specifically the first session, I think what is happening here is really unacceptable. So in summary, I think in large areas of the world with limited research governance, a lot of the research actually is fabricated. The publishing system, including peer review, is not able to deal with this. And I'm sad to say that a large part of the academic community is looking away from this problem. So there are a set of measures that we can take. I think the rules to investigate could be much better. I feel sometimes that if you go to these institutes and ask for an investigation, that is asking the Russian authorities to check their own ethics for doping checks, right? I mean, medicine is maybe the Olympic Games without any doping checks. But I think we can do much better, and I would encourage everyone to be critical in the area what you see. If you don't have it installed, PubPeer is a software facility around PubMed that allows the comments that other people gave on papers to see you, to point you at that. And for me, I don't know exactly what the solution is going to be, but the current situation is unacceptable. Thank you very much.